This video for illustration of adrenergic receptors. Before I start explaining these adrenergic receptors, I want to mention two concepts. The first concept I want you to know is presynaptic receptors versus postsynaptic receptors. What does presynaptic and postsynaptic mean? Because you will hear about these terms very often while you study. Number two, we want to discuss a term called second messenger. What does second messenger mean? Let's start with the first concept, presynaptic and postsynaptic. Consider this any nerve fiber. This is the nerve body and it's connecting to another nerve body anywhere either in CNS or peripherally. If there is a receptor present here, let's call it alpha 2 or beta 2. And if the same receptor is also present here, alpha 2 and beta 2, remember that this attachment or this space here is called synapse. Which of these are called postsynaptic and which are presynaptic? Look at the direction of the chemical transmitter from where it comes and to where it goes. If the chemical transmitter is moving in this direction from this cell to this one, or let's assume this is a tissue instead, and this is a nerve terminal, and signal is moving in this direction, then the receptors present on the neuron or nerve terminal which releases the transmitter is called presynaptic. Pre because this space is called synapse and it's located before, so it's presynaptic. On the same principle, the other receptors present on the cell or this tissue are called postsynaptic. This is for the terms pre and postsynaptic. Okay? Now before we dwell into details, may I ask you, does this presynaptic receptor has anything to do with this tissue? Or its function is only about its own nerve cell? Its function stops in here. So, this presynaptic receptor present on any nerve terminal or any neuron releasing transmitters, if you say presynaptic, then you mean that its only function is to regulate the release of transmitters from this nerve terminal or this cell releasing transmitters. However, it has nothing to do with the tissue itself or the responder. On the other hand, if we say that the transmitter is released from here to here in this direction, this is the receptor is called presynaptic and this one is a postsynaptic. To avoid any confusion, if you hear the term presynaptic receptor from now till we finish all of the lectures, when you hear presynaptic, then it means these are the receptors located at presynaptic membrane. Its function is to regulate transmitters release, so some of them increase, others decrease, as we will see now. For now, if you hear presynaptic, then its function is not in the tissue, but it's to regulate transmitters release. This is the first concept. Second one is something called second messenger. Naturally, we will specify huge part in general pharmacology chapter only for receptors. We will discuss them in detail. But for now, at least you know most of the receptors are present on cell membrane. If this is a cell, then the receptor is here on cell membrane. The receptor doesn't ever perform any function when it binds to its agonist. It can only act through something called second messenger. This second messenger might be a G protein, it might be a kinase, a protein kinase, it might be tyrosine kinase and so on. Or this receptor might be working through ion channel. In other words, there is no receptor working directly like this, except for, focus on this one, except for only one type of receptors. Its activation can lead to immediate outcome. Do you know which one this might be? Let me remind you. Do you remember ganglia from the past video? This ganglia contains acetylcholine. When released, it opens a gate. Do you remember its name? This gate is called nicotinic acetylcholine receptor. This receptor here called nicotinic acetylcholine receptor is the only type of receptors which by its activation the gate opens, resulting in sodium ion influx leading to depolarization of tissue. So the only type producing immediate outcome and acts quickly without second messenger is this type called ion channel linked receptor. If you have an MCQ question stating this, the only type of receptors that has no second messenger, then it is the first type of receptors. Naturally, we will explain all of this in detail on general chapter, but for now, at least you have an idea about it. So it is the first type called ion channel linked receptor. Except for this one, any other type of receptors acts through second messenger. Now, how many types of receptors are present in your body? You have 4 types. I won't discuss them in detail now. However, you should know that 70% of receptors in your body, 70% of the overall number of receptors present inside your body are something called G protein linked receptors. So 70% of receptors inside your body are G protein linked receptors. Like this one we are explaining in this video, which is adrenergic receptors. All of the adrenergic receptors are G protein linked receptors. Don't forget this, 70% of receptors we have are G protein linked receptors acting through second messenger. This second messenger might be a G protein, protein kinase, ion channel, or whatever. This is the second concept. Let's now talk about the types of adrenergic receptors and discuss them in detail. In the past video, Physiology Introduction, I told you that adrenergic system or sympathetic system main transmitter is noradrenaline or norepinephrine, and when it is released, it can affect or activate 5 types of receptors. First type is alpha 1, second type is alpha 2, third is beta 1, fourth is beta 2, and the last one is beta 3. Those are the 5 common types of adrenergic receptors that adrenaline or noradrenaline can act on. And as I told you, any tissue has one type of these as predominant one. It may indeed have more than one type, but only one is the predominant, exerting the most marked influence. Let's talk about this alpha 1 firstly, discussing its sites, functions, and its second messenger. Which type of second messenger? This alpha 1? Before anything, you should know that recently there is nothing called alpha 1 anymore. It's divided into subtypes. We now have subtype A, B, D, and there are more, but only keep these 3 in mind. Alpha 2 is divided into A, B, and C. We can no longer say alpha 1 and stop. Instead, we say that a certain tissue has alpha 1A specifically. They are slightly different from another tissue with alpha 1D, and so on. The first and the most important site for this alpha receptor is blood vessels. Most of blood vessels you have contain alpha, and its activation results in vasoconstriction. If you want to be more scientifically exact, it is 1 alpha A specifically. Most blood vessels contain alpha 1A receptor. Its function is vasoconstriction. Number 2 is the uterus. Alpha receptors in the uterus also cause contraction. However, it's somehow weak in there. So I don't want someone to say that we can make use of this receptor to induce an abortion in a pregnant woman. It does cause contraction, but not so strong that it could lead to abortion. Consider this effect to be theoretical. Theoretically, it can cause contraction. Third site is the eye. Here is the eye. This is the pupil. Here is something called radial muscles that you call dilator pupillae. These dilator pupillae contain alpha 1. When it is activated, it leads to contraction. Note that alpha 1 is always causing contraction or constriction, and you will see the reason. When this alpha is activated in the eye, it leads to contraction of the radial muscles of the eye, so the pupil dilates. And when the pupil dilates, it's called mydriasis, as you know from physiology. When someone experiences sympathetic stimulation, his pupil must dilate for a better vision in order to face the danger. Fourth site for alpha 1 receptors, this is GIT and this is the urinary tract. Let's talk about them as one. In both of them, we always have a wall and we always have a sphincter. Alpha 1, if it's found in the wall, then it causes relaxation, and this is an exception because I told you alpha 1 always causes contraction. If it's found in the wall of the urinary system, it also causes relaxation. But in sphincters, it causes contraction. If you want to be more scientifically exact, Here in the sphincter, we have alpha 1A and alpha 1D. So in the sphincter, we have alpha 1A and D causing contraction. Why are we saying this? That's because when we discuss the drugs, I'll tell you that whenever you invent a drug, it's better to target only one specific subtype. Why? Because if you want to act on blood vessels only, then you should target alpha 1A. If you want to act on sphincter, you have alpha 1A and D. Then you should choose a drug that acts on alpha 1D. Considering that, this subtype is not very common except in sphincters. So if you have a patient complaining of urine retention, which one is the accused? Of course, it is the alpha receptor. So we should give him alpha blocker. When we block this alpha receptor, the sphincter opens and urine come out. In the past, we used to do this. Not very far in the past, but about 20 years ago. When someone complained of urine retention, we used to give him alpha blocker. Do you know what did these people complain of? These patients who received alpha blockers complained firstly of dizziness. Do you know why was he dizzy? It's simple. As you can see, when I gave him alpha blocker to block alpha here, which was responsible for sphincter contraction and urine retention, this alpha blocker I gave it to the patient was non-selective, so it blocked alpha here and it did solve this problem. However, it also blocked alpha receptors in blood vessels, leading to loss of vasoconstriction, resulting in low blood pressure. So if you are smart enough and you want to invent a drug that only acts on the sphincter without affecting blood pressure, then you invent a drug that blocks only alpha 1D. Why this alpha 1D? Because it's present only in sphincters. Blood vessels doesn't have alpha 1D. This is the progress in medicine, and these are the new drugs, but don't mind with their names now. I only want to show you how important subtype functions can be. A new subtype discovery means that a new drug is on the way, which is more selective. This high selectivity decreases its side effects on other tissue. These are most of the parts in your body that contain alpha receptors. There is only one place left, which we don't care about that much, but let's have a quick glimpse on it anyway. Do you remember in the past video when I told you about sweat glands? Do you remember the autonomic supply of sweat glands? Is it sympathetic or parasympathetic? Yes, they are supplied by sympathetic system, but then I told you, although they are supplied by sympathetic, their transmitter is acetylcholine. That's why we called the nerve supplying these sweat glands sympathetic cholinergic. So the receptors in these glands should respond to acetylcholine. Accordingly, they are not supposed to belong to this family of adrenergic receptors. However, some of the sweat glands, especially those in the palms and forehead, still obey the rule. In other words, they are supplied by sympathetic and their nerve endings release noradrenaline, and the responders that respond to it and make your hand and forehead sweaty is alpha 1. So we have two types of sweat glands in our body. One that's cholinergic, and this is the most common all over the body, and one that's adrenergic, present in the forehead and the palms, because its nerve is sympathetic, releasing noradrenaline, which acts on alpha 1. Again, if we want to enumerate the sites of alpha 1 receptors, they are present in blood vessels causing vasoconstriction, they are present in the uterus, their effect is weak but still contraction, they are present in the radial muscles of the eye, they cause contraction. But be aware of this, for MCQ, they don't cause contraction of the pupil. They indeed cause contraction, but not for the pupil, they cause contraction of the radial muscles of the eye. They are also present in the wall of GIT and urinary tract, causing relaxation. They are present in the sphincters, causing contraction. We are missing only one thing which you may be wondering about now. In all of these places, why do alpha 1 receptors cause contraction everywhere, except in the wall of GIT and urinary tract where they cause relaxation? Here we need to return to the concept of second messenger that I told you about at the start of the video. This is explained by second messenger. Regarding alpha 1, if this is a cell and this is alpha 1 receptor present on cell membrane, when it's activated, it activates something called G protein Q type, We have 3 types of G protein, and maybe there are more than just 3. As you know from biochemistry, we have 3 types of G protein: G stimulatory, G inhibitory, and third type is called GQ. Q is short for query or questionable. When this GQ works, it increases something called inositol triphosphate or IP3. And when IP3 increases, it increases calcium. You know from physiology that this calcium is an incinerator. Calcium never acts for the sake of common good. It's never possible for calcium to increase causing relaxation. Increased calcium level in any cell, if that cell was contractile, it leads to contraction. This is why blood vessels contract. You know that when alpha-1 works, it leads to vasoconstriction. This is explained on the molecular level by these steps. Alpha-1 activation turns on GQ, increasing IP3 level, which increases calcium level. This increased calcium is the reason behind vasoconstriction, okay? So much so that when we want to induce relaxation in any tissue, we use drugs I'll tell you about later. They are called calcium channel blockers. Calcium blockers, because you know that the calcium always leads to contraction. But then, what drives GIT and urinary bladder to deviate from this rule? It's supposed that the alpha activates GQ, increasing IP3, increasing calcium. Do you know why GIT and urinary bladder rules deviate from the rule? It's very simple reason. If we assume this to be a cell from GIT wall, when calcium level is increased within the cell of GIT wall, it opens a certain type of potassium channel called calcium dependent potassium channel. Originally, increased calcium level leads to activation of a certain enzyme called, don't bother with the name, but anyway, it's called myosin light chain kinase. This myosin light chain kinase is the one causing contraction. However, in the wall of the GIT and urinary tract, this enzyme is absent. Instead, there is a certain potassium channel. When calcium level is increased, it opens this type of potassium channel, and you know what? When potassium channels open, this cell is somehow paralyzed. This cell now is paralyzed, and this paralysis in medical terms is called relaxation. Again, if some examiner wants to intimidate you during oral exam like this, dear student, can you tell me why doesn't this alpha have any good intentions? Tell him indeed it doesn't, because it always causes contraction. He will then ask you, but why? Tell him because it turns on GQ, and GQ increases IP3, leading to increased level of calcium. If he wants to pressurize you further, he would then ask you, and what does calcium do? Tell him it acts on enzyme called myosin light chain kinase, causing contraction. He would then say, but I think it can cause relaxation in GIT and urinary bladder walls. Tell him that this is right, because their walls doesn't have this enzyme. Instead, they have a potassium channel called calcium dependent potassium channel that opens in response to increased calcium, leading to hyperpolarization of the wall, resulting in relaxation. For now, this is all what we need to know about this alpha. So let's start discussing alpha 2. Alpha 2 is too kind that it won't take too much time. I'll only tell you one word and leave you to your own devices. If I tell you that most of alpha 2 in your body, more than 90% of this alpha 2 distributed in your body are presynaptic. That's it. I'm saying no more. I'm leaving you to your own devices. What does presynaptic mean? It means it's present on the nerve terminal. If this is a nerve terminal and this is a tissue and this is synapse, does alpha 2 act on tissue or on its nerve terminal? Of course, on the nerve terminal. Its function is regulatory, as I told you before, and this alpha 2 is nearly always opposite of alpha 1. This one was far from good, always contraction and so on. On the other hand, this one is inhibitory. It decreases norepinephrine release, calming you down. Patients relax, humans relax. Who is the nervous one? He is the one with malfunctioning alpha 2. And since alpha 2 is malfunctioning, then this one is releasing more than enough norepinephrine. In such conditions, when someone complains of always feeling nervous and you want to calm him down, give him a drug that activates alpha 2. We invented drugs for this purpose, to activate this alpha 2. For example, if a drug addict came to us, now he has repented, opened a cigarette booth, and he's no longer taking drugs. He may come to you complaining of anxiety and tension. In this situation, if you want to calm him down, you tell him that instead of taking substance for relaxation, stop this and I'll give you a drug that stimulates alpha-2 receptors. When I stimulate your alpha-2 in the brain and peripheral nerves, it's a presynaptic receptor that decreases norepinephrine release, so you will be calmer and more relaxed. This is the best use of these drugs that activates alpha-2, and we call them selective alpha-2 agonists or stimulants. We have alpha-2 in many other tissue. It's also present postsynaptic, but it's somehow weak. I told you that more than 90% of them are presynaptic for regulating norepinephrine release, decreasing norepinephrine release. Okay? Now let's shift to beta-1. Beta-1 is the commander of the heart, so that it's called cardiac beta-1. Its most well-known place is the heart, and its activation leads to increase all of the cardiac properties. Count with me, from heart rate to automaticity, rhythmicity, contractility, and so on. It increases all of the cardiac properties, and when you have a patient complaining of arrhythmia or tachycardia, this beta-1 could be responsible for this. Then you have to give him a beta blocker. Until now, we don't know if it has subtypes or not. Let's hope to discover its subtypes soon. I'm sure it has subtypes, but this is not important for you. So beta-1 is present in the heart, not only there, but it is also present in the kidney. If you want to target this beta-1 in the heart, search for its subtypes and invent a drug targeting them in order to be more selective. Those are the most well-known places for beta-1. It's present in the kidneys and it's present in the heart. This beta-1 is also present in lipocytes or adipocytes, fat tissue cells. However, beta-3 is the predominant type there. So if someone asks you whether your adipose tissue have beta-1, then the answer is yes. But when we talk about adipocytes or fat cells, it's always the beta-3 that has the most of the effect there. It is their specialty. The playground of beta-3 is adipocytes. If beta-1 is mentioned, just don't forget it's present in the heart and in the kidney. This is all what I want you to know. Now, beta-2. Beta-2 is called the kind beta-2. Why the kind? By the way, receptors taken number 2 are always kind and considerate, and receptors taken number 1 are almost always rogue. Now, why are beta-2 called the kind beta-2? Because it is the one responsible for running. This is the hero saving you when, God forbid, a dog chases you, or while you are climbing the stairs, perish the thought, a hairy cat runs into you in the dark. This beta-2 is the one saving you on such occasions. In Egypt, when we face something terrifying, we say that running is half of the courage. And this beta-2 is the one responsible for this courageous half. But why? Number 1, if I am facing a threat and I need to run away, what is the first thing I need? It is skeletal muscles, correct? I need skeletal muscles, so this beta-2 dilates your blood vessels present in skeletal muscles to give them more blood so you can run. Do you know why? It's because if beta-2 didn't do this, alpha-1 would cause vasoconstriction, and this is very bad. If you tried to run, you would have a cramp. However, this beta-2 prevents this one from affecting skeletal muscles. Skeletal muscles blood vessels are dilated under the effect of beta-1. Not only this, but do you remember when I told you that skeletal muscles have nerve endings releasing acetylcholine? Do you remember the name of the receptor responding for acetylcholine from the past video? It's a gate called nicotinic acetylcholine receptor, muscular type. Do you remember this word? This one is supposed to be acetylcholine. Then what is the role of beta-2? Beta-2 makes this receptor called nicotinic acetylcholine receptor become more sensitive to acetylcholine. Why we need it to be more sensitive? So we can run quickly, so we can depend on our muscles. This is the term that you read and wonder about its meaning. This is called facilitation of the neuromuscular transmission. This term means that beta-2 increases blood flow to the muscles and also makes this receptor that respond to acetylcholine become more sensitive, resulting in a quicker and better response. These are two functions within the muscles. Still, we have a third one. But before the third one, let me remind you with something you had in physiology. In order for a cell to have action potential, one sodium ion gets inside for exchange of one potassium ion. You call this action potential and depolarization. Now, in order for muscle to contract, causing muscular contraction, shouldn't sodium get inside cells, potassium get out, and this process occur very rapidly so we can run? But if you don't have potassium in your muscles, can you run? If potassium stores in muscles are low, can you start running? Sodium get inside muscle cells causing depolarization, but it wouldn't find potassium to get out for exchange. This can result in disruption of the action potential, and this is the role of beta-2 receptors. These beta-2 receptors drive potassium ions from blood into the cells, causing something known as potassium shift. It quickly draws potassium ions from the blood and push them inside muscle cells, so they have sufficient potassium stores for action potentials, facilitating muscle contraction. Muscle contracts quicker without fatigue. They increased potassium level in cells, but they decreased its level in the blood, resulting in hypokalemia. Potassium is not sufficient in the blood. Be careful not to mix these effects with each other. I want you to understand when I tell you how does beta-2 affect potassium. If you say it causes hypokalemia, you are right, although it didn't mean to cause hypokalemia. Beta-2 didn't intend to cause hypokalemia specifically. It only intends to increase potassium ions inside the muscles, so it draws them from blood. In other words, beta-2 had good intentions. It only wanted to facilitate muscle contraction, but it didn't intend to cause hypokalemia. These are three effects on the level of muscles. It increases blood flow, it facilitates neuromuscular transmission, and it draws potassium from blood into the muscles, causing hypokalemia. Not only this, but you know that when we are running we need our heart, right? Heart rate is increased and this beta-1 is supposed to increase contractility. This beta-2 helps beta-1 through coronary dilatation. Dilatation of the coronary artery, so it's causing dilatation in two places, skeletal muscle blood vessels and coronary arteries. Both of them you need during running. These two places has nothing to do with alpha for now. During running, skeletal muscles and coronaries are under beta-2 control, which causes vasodilation. We didn't finish it. While you are running, you need to pant. So what do you think happened to bronchi? Do you think they constrict? You would die then. Beta-2 causes bronchodilation, so you can breathe easily during running. And when you run, don't you need high blood sugar? So you can think a muscle can contract? Where can you get the sugar from? From the liver. Liver is storing sugar in the form called glycogen. Okay, this beta-2 dissolves some of this glycogen, releasing glucose into blood to enhance muscle performance and cognition function, so you can react. You can decide how to escape from this dog, which route is the best. Sugar helps you in this. Count with me all of these functions. I don't memorize them, so let's try to remember them together. It has three effects on muscles. It causes vasodilation of skeletal muscles blood vessels, and it causes facilitation of neuromuscular transmission resulting in better muscular performance, and it increases potassium stores inside muscles. From where does it come? From blood. Number 4, it increases blood glucose level. From where? From liver. How? By glycogenolysis. Number 5, it causes bronchodilation, so you can take good breaths while you run. Number 6, while you run, air pressure can affect the eye. If you are running quickly, air pressure is increased on the eyes. Let's assume this is an eye. This is cornea and this is sclera. This is front image. This is the iris. This is a lens. This is suspensory ligament of the lens. This is the ciliary body and choroid. Here is something called ciliary epithelium. This ciliary epithelium, which has beta-2 receptor. is responsible for secretion of the fluid inside your eye, which preserves intraocular tension. Your eye contains fluid in the anterior and posterior chambers. Both of them are filled with fluid called aqueous humor. Where does it come from? From epithelium lining ciliary body called ciliary epithelium. It has beta 2 responsible for secretion of this fluid. What does this have to do with running? While you run, air pressure on the eyes is increased and we cannot let this continue. Here are pressure sensors. They sense the pressure. Once they feel increased air pressure, they activate beta 2 receptor to increase aqueous humor secretion. It doesn't intend to harm you with increase in aqueous humor, but to confront this increase in the air pressure during running. Now you stop running and air pressure is back to normal. Then this aqueous humor is absorbed and drained through something called angle of the eye to canal of Schlemm to the episcleral veins and lymphatics. That's okay, all of this, and we didn't deviate from the word running. Running is half of the carriage. This beta 2 is the hero responsible for this carriage. Okay, is there anything else? Yes, there's something else. Imagine if you have a pregnant woman in your clinic who was unable to conceive for many years, 15 years or so. Then she finally was able to get pregnant. Now she's praying for God every day and doing charity because she's now pregnant. Imagine if this pregnant woman is being chased by a stray dog. What on earth is this? If she was frightened and ran away, she would likely have an abortion. That's why God's blessing her with beta 2 receptors in the uterus. Do you remember when I told you that uterus have alpha 1 but its effect is unremarkable? On the other hand, beta 2 effect on the uterus is extremely powerful. It causes uterine relaxation during danger to avoid abortion. Do you get it now? Why we are calling this kind beta 2 receptor? So be careful during exams, as some examiner may try to deceive you and ask you, do you know a drug that can block beta 2 receptor? Tell him I can understand if you want a drug blocking all types of receptors together. But why beta 2 specifically? It didn't do anything bad. Maybe the only undesirable effect of it is when it improves muscle contraction by facilitation of the neuromuscular transmission in order to improve performance. It might sometimes cause handshake. This facilitation can sometimes result in this shake, which we call tremors. This may be the only undesirable effect of beta 2. Sometimes people can complain to you of hand shaking, especially those working in a shooting range. These people may complain of shaky hands during targeting. Tell him it's because of beta 2 in your hands. It's slightly overactive in your hands during their facilitation of the neuromuscular transmission, and this is what causes these tremors. This is the only undesirable effect, and I can prescribe a beta blocker in this situation to remove these tremors. If this man wants to cheat, he may have a shooting test and he wants a steady hands during this test. Give him a beta blocker, blocking beta receptors, which causes this tremor, so his hand can be steady and he can pass. So all in all, beta 2 is always kind and doesn't mean to cause any harm except for these tremors. This is a very simple effect. Now we only have beta 3 left, and you already know something about it. By the way, this beta 3 could be considered a different type of beta 2. It's scientifically considered as a subtype of beta 2. However, it's present in the adipose tissue causing lipolysis, melting the fat. Needless to say, once you hear that it melts the fat, people who are watching this video right now will say, that's it, we have found it. You are thinking about weight loss, aren't you? This is good, you have a sound mind and you are trying to make good application of science. However, allow me to destroy your happiness. Why? Because if beta 3 had been uniformly distributed all over your fat, if it had been present in the fat of my face, hands, all of my body evenly, I would have invented a drug stimulating it, causing lipolysis, allowing us to get rid of this fat without much effort. But sadly enough, these beta 3 receptors are present more in the upper half of the body. They are present more in the face, hands, but they are not present in the belly fat. Accordingly, if you stimulate beta 3 receptors, certain area of your body lose fat but other areas don't. Your face would be thinner, but your belly fat would remain the same. That's why we couldn't make much benefit from them. So if you see a question in exam asking why don't we have beta 3 agonists, as these receptors are supposed to induce lipolysis, so why don't we have a beta 3 agonist among drugs treating obesity? Pick this peculiar sentence from the choices. Because it is not evenly distributed throughout the body, this is the answer. There is only one last concept before we end this video. I told you that alpha 1 second messenger is Which type of messenger? I told you that alpha 1 activation turns on a protein called GQ. Do you remember? All types of beta receptors, when they are activated, they turn on the same second messenger called cyclic AMP. When cyclic AMP is increased inside cells, it causes all of these effects which we discussed. So why don't they all have the same function? Why are beta 1, 2 and 3 doing different functions? It's because when cyclic AMP is increased, it activates other subcellular components, other kinases. Kinase here is different from the one here and here. Again, so you don't miss this concept. If someone asks you what type are beta receptors present in your body, tell him G protein linked receptors. But how does this beta receptor function? Tell him it increases cyclic AMP inside cells. But then, why beta 1 receptors in the heart increase contractility while beta 2 causes relaxation? Although both of them increase the same cyclic AMP? Tell him it is not all about cyclic AMP, but what's present behind this cyclic AMP. When cyclic AMP is increased in the heart, it activates a certain protein kinase, which is different from the kinase present in the cells that are under the effect of beta 3. So it's not all about the receptor, it's not all about G protein. However, it's all about further enzymes, final effectors at the subcellular level. Remember this, so no one can trap you during oral exams. Now we have finished the main concepts about adrenergic receptors. See you in the next video.